So again, everyone, thank you so much. It's wonderful. I see some repeat attendees to the surgical and clinical bootcamp series. We know that there's been a lot of virtual graduation and some of the programs have stopped for their summer break. So we appreciate those that are attending with us tonight. Very excited. We have two fabulous presenters. We have Dr. Robert Seymour. He is a multi-PDS supported owner dentist out of Arizona. And we also have Dr. Emilio Arguello. He is a periodontist, not only here in Colorado, but he supports many practices, and you'll get to hear more about him in just a moment. Tonight's topic is life in the real world, especially after residency and dental school, and how a restorative dentist and periodontist collaborate for a perfect patient experience. They're going to share with you some of their best practices and case studies that I think you'll find very interesting. Before we get started though, if I may ask, as a reminder, we are offering 1 CE credit. So I'll need to make sure to have your name first and last in the registration. So on your screen where it has the 3 dots, if it just has your first name, if you could please change to your first and last, it'll make it easier for me to identify you in the system for CE credits. And you will receive a CE certification within 4 to 5 business days. Also, we're excited to share that in the Surgical Bootcamp series, we're offering a $100 Amazon gift card. So for those of you that have been attending the series, we'll be doing a drawing on Friday, and we'll notify you who has won the $100 gift card. This webinar will be recorded. So a participant guide and recording will be available to you within the next 24 to 48 hours once we have everything collaborated and put together. In short, if you need to get off and rejoin the webinar, if you'll please make sure that you stay on mute, that would be fantastic. And lastly, if you have any questions, I'll be your moderator for this evening. My name is Kimberly Brozovich, the Director of University Relations. And at certain points throughout the webinar, I'll certainly delegate those questions to the doctors to see how we can most support you with those answers. So Dr. Seymour, I'll let you get us started for our webinar this evening. Thank you both so much for joining us.
Great. And Dr. Emilio, feel free to jump in anytime. Like Kim was saying, I've been practicing a long time. I graduated in 2008. I've helped Minnesota open up a lot of offices, and here in Arizona. So what I get to do is I get to help a lot of young doctors and a lot of specialists kind of build up their practices, and I kind of watch what the big misses are. And so I'm going to spend the first 15, 20 minutes with you, and Dr. Emilio is going to spend the next half kind of going from a periodontist perspective on the 5 kind of the misses and what we can do to better make referrals for our specialists. And so I kind of wanted to go from there. So this is just a little bit of the background for me. I really love implants. I've had the same oral surgeon and periodontist for 10 years. I've got 4 practices in Arizona and 10 practices in Minnesota, but I practice in 1 office. That's what I do, and then I just help out in the others. So there should be a question box. If there is and you want to kind of ask a question, just go ahead and drop it in that box, but I'm going to get right down to it. There we go, referring to your periodontist. Okay, here we go. When we refer to a periodontist, we're looking for reasons why. 5 millimeter probing depths are greater after SRPs. Sometimes I've seen associate doctors just send them right from the get-go. No, we need that cleaned up. The periodontist needs that cleaned up. And then if we're seeing it kind of lingering and not holding, then we're thinking of osseous surgery and cleaning that up. Patients with periodontal disease, patients with gingival recession, soft and hard tissue deformities, pre-prosthetic surgeries, alveoloplasties, tori removal, teeth extractions. A lot of people miss the bone grafting opportunity of teeth extractions. I've always been a big believer that bone grafting is the #1 missed dental procedure that benefits patients and also prevents complications. Such as not being able to control heme. So referring to your periodontist, they are keen on placing that bone graft in those teeth extractions. Orthodontic adjunctive procedures, implant site development. I'm going to focus on this tonight, as such as ridge augmentations and sinus elevations. when you see that word ridge augmentation, you need to have it go back to your kind of core concepts of implants: bone quantity and quality, and the composition of the gingiva is what I'm looking for and what the periodontist is looking for. So let's send good referrals over to the periodontist, and tonight we're going to kind of go hit a couple cases on exactly what that looks like. Emilio, you need to do me a favor. In about 15 minutes, if I'm going on, Dr. Emilio, you're going to jump in with me. Can you guys hear me?
Absolutely, no problem. Thank you.
Okay, cool. And anytime you want to jump in, doctor, just let me know. Okay, dental implants, immediate implants, full mouth rehabilitation, or the all-on-4 procedure, or the click-on dentures with implants. My periodontist in my office is a board-certified periodontist and prosthodontist, and has taught me a lot, has mentored me a lot. So I'm hoping to relay that information to you tonight. So communication is the key, clearly documenting, clearly going. What does an ideal referral look like? Ideal referral looks like, well, I'm going to tell you what the big misses are first that constantly happen in all of dentistry, and where patients fall into the cracks and then just never make it to the periodontist. Okay, we're going to hit that tonight, and we're going to go over. You should be referring when you are out of your comfort zone. If when in doubt, refer it out, but we need to also know what the periodontist can't do. Sometimes we refer to the specialist, and there's things that just aren't possible. And so we might address that a little bit tonight. Always want to consult. I've got my periodontist on text, and we consult frequently over that. All right, good. And then every month we do get together. In fact, every time he's in the office, we get together and kind of calibrate together. And that's kind of what the PDS model is. The PDS model is I have ortho, endo, perio, and oral surgery, and they all come in multiple times a month. So, and it's fun. It's really good. It's really good. Patients love it, and they love it from the fact that it's all in one place. All right, here we go. So we're going to jump into cases, and I'm going to try and do this. I'm going to go through the 5 misses first, and then I'm going to try and show a video to you guys on what an implant case should look like and how smooth it is, and then we'll go from there. All right, so big misses. The thin ridge club. My oral surgeon has taught me this, and my periodontist has taught me. Sometimes we're referring, these are the misses, sometimes we're referring when there's not enough bone, and we make the mistake of when the gum tissues look thick, or when the bone looks thick, but really the gum tissues are thick, and we need to be very careful. We can't put in implants on the thin ridge. So watching out that. Incomplete medical history. That's very common, very, very common in our world, that we don't have an accurate record of their medical history, their medicines, and also of their periodontal history. We're sending patients over that have uncontrolled diabetes or uncontrolled periodontal disease. Then sometimes the new referral grad they'll send for immediate implants, and when there is significant amount of granulation tissue in the bone, we miss it. We can't put that implant in there, and so we need to graft that site first and do a delayed approach instead of the immediate approach. So setting up correct expectations for the patient is critical right there. Okay, then the last one is poor communication, and I put unstable there, and people are like, what does that mean, unstable? Patients need to be able to understand. They need to be cognitive of what's happening and what they're getting and why they're getting it, and they need to know. And as clinicians and as providers and as referrers, we need to be able to hand that off appropriately so that when they do go to the periodontist, that they have an accurate idea of what's going to happen. This is what the consultation is going to look like. We've treated your SRPs, now we're going to be looking at, and it's not controlled, your pockets aren't resolving, so we're going to be looking at doing a surgical approach to resolve your periodontal disease. Okay, so that's a good one. That's a great one. Okay, so I have taught implants to my associates and to implant boot camps and all over. And sometimes it's difficult to tell young doctors, okay, what's good? How do you refer? What's good not to refer? And so I've come up with a system. And this is my family. is in Colorado, and they like to ski. And these are my 3 girls. And I just want to tell you, the first time we skied was a nightmare, much like our referrals. Your first handful can be somewhat messed up. Well, then after some practice and some communication, it gets a lot of fun. And our family, we really enjoy getting together. Even that little one, that little 6-year-old, she can zoom down the hill. I think that little 6-year-old, my Everly, she can beat Ashley down the hill any day of the week. So it's a lot of fun. But with practice, you get good. So I relate it to skiing with implants and with periodontal referrals. So here you go. So I have broken up your implants or your referrals to the periodontist based on green runs, blue runs, black diamond, and then double black diamonds. And double black diamonds are, not even the specialist can do this. And I want you to think of a mandibular ridge that's so thin and so small that it's dangerous to place an implant in there in fear of cracking that or breaking that mandible. So that's one thought process. As far as novice or a green run, something that's going to be easy. Your periodontist is going to send you, tickets to the basketball game. They'll be like, hey, that was a great one. Thank you so much. And that was a good patient that has good comprehension and understanding of what's going on. That I love the green runs. Where we get a little bit confused is in the black diamond and in the blue diamond. In the black diamond, this is for experts only. This is for the periodontist. Both blue and blacks are for the periodontist. This is where they excel. And their skills are needed, and we need to get them to them. So when you think about patient selection, restorative goals, bone quality, bone quantity, and tissue type, and anatomical kind of pitfalls, as you go through and you kind of break down your patients, say, okay, what is their tissue type like? Are they well-controlled periodontal disease? Is this keratinized gingiva? If you're going down and there's no issues, then you're kind of be heading towards green. But the more you get, the more of these complexity items you get, the more problems or problematic this can get for both the specialist and for the general dentist. Remember, we've got to restore and we got to do this right, so we need to be in good communication. Okay, so I'm going to kind of do a couple cases here real quick and see if I can kind of stoke the fires of thought and see if I can get you to know a little bit better what a double black diamond is. Really, no one should be going down that run unless you want to get hurt. Black diamond, experts only, blue diamond, experts with some mentorship, green, let's all look to that. Okay, let's see what we got here. Okay, so in your mind, I want you to go through and say, okay, is this case study a green, blue, black, or double black? And yes, this is dependent on your skill sets. This is dependent on your experience level. But I want you to kind of all to sit back and look, okay, is this going to be a green run for the periodontist? Is this going to be a blue run for the periodontist? Is this going to be a black run? Or is this going to be, okay, he might send this back. Okay, so let's try this one out. All right, here we go. So in your mind, I want you to go through these 5 items, okay? What's the tissue type? Is it mucosal tissue, or is the biotype thin here? Or is this keratinized coral pink? This is keratinized coral pink, okay? So we've talked about tissue. I'll give you the background on the patient because this is a real patient. This patient is amazing, understands big knuckles, good guy, just a great guy. Okay. All right, now let's go to the next ideas. Bone quantity and bone quality. With those big knuckles and that tori, I know that bone is going to be good. And I've extracted these teeth and grafted this site. So I know the bone quality and quantity is going to be good. A really good rule of thumb is most implants are about 4 millimeters to 5 millimeters across on the platform, right there. And I envision right on that tissue, the 5 millimeter platform. And am I going to have 2 millimeters all the way around it so I can get good blood supply to that implant? That is what I'm looking for. So now I measure this out. This looks like a good spot for 2 implants. So I actually have that little calculation that has the implant width with the necessary spaces in between natural teeth and implant teeth, which is 3 and 2. And then we get that all going. Okay, so now we're going to go to the next one. So I wish you guys can all raise your hand and vote. I wish we had electronic voting right now so you guys could all put your hands up on what this one is. And yes, this one is a green run. This is, you send this, your specialist will love you. Dr. Emilio, what do you think? Would you love this in your practice or what?
Any day of the week, please send them over.
like when you see that tori, what does that make you think?
Well, we have plenty of room to be able to place the implants in the correct prosthetic position and being able to be successful at the end. And if we need to actually have some bone deficiencies in other sides of the mouth, we'll use that bone to transfer to the other sides of the mouth. So,
right? I mean, this is a dream. This is a dream. This would be a green run. We'll go out to dinner after this one.
I like it.
All right. Let's get to the next one. Thank you, doctor. All right, here we go. This was a patient, female, late 60s, was very excited to get implants, came in right from the get-go to the front desk. I want implants right here. And this, now I want you to go through the 5 steps. Don't just go with, okay, what do I think? Or, oh, the patient's excited. Let's get the implant in there. Go, think it through. Go tissue type. I do have a little bit higher line of the mucosal tissue or the thin biotype coming up. I've got a depression there in the buccal bone. I know that this is the mandible and it's in the posterior because I can see the tongue. And I know I've got that mandibular sublingual depression there. So my levels of complexity are going up. Well, I know that if I reflect that tissue tissue is probably pretty thin and there is no bone right there, right where that dip is. And I almost want to put my finger in that little spot to see how much is really there. Can I even put this in? So this question, so my oral surgeon, we sent this to my oral surgeon and now you guys can, oh, here's a trick. Okay, the pano. What is the pano going to look like? The pano will not show this buccal depression. The pano is going to show a normal bone and that will trick you into getting into something that is not appropriate or it just won't work. Forget about appropriate, it just won't work. So be careful with that pano and those bite wings because it's only a 2-dimensional image. All those items, all those tools should be used in conjunction to kind of create a good picture of if this is possible. So refer, so case study 2, what do you guys think? Green run, blue run, black run, double black. My personal Dr. Emilio, what would you put it as?
I will put it between blue and black.
Yes, for the periodontist, that's a blue and black. For me, if I was thinking about placing the implant, I would be like, nope, double black diamond, I'm out. I'm out. And I'd be sending this black to the periodontist immediately. And yes, that one was very difficult, and I wish I would have had the after. We had to do a split ridge right there where we reflect the flap, split the ridge, add bone to get some buccal depth to that. So it was a double delayed process. Let me restate that. We ridge augment, wait 4 months. Then we place the implant, wait 4 months. That's a 2-delay process. So calibrating the patient's mind there is going to be really important. All right, case study number 2. I'm cooking right through these. We're moving fast. Okay, here we go. This is a car accident. Guy was young. He came in and he said, my lower mandibular teeth, he didn't say mandibular, but he said my lower teeth are moving and they hurt. And they were moving, and you can see somebody else try to splint those incisors together. And they were moving, okay? So let's think this through. All right, this is what ended up happening. I'm just gonna get right to it. Double black diamond. This was a very young doctor referring and a very young oral surgeon. Okay, so I want you guys to think this through. Okay, and they went for it. Well, if you go for it, what kind of baggage are you gonna get? This is it. Those implants are too close. They're gonna have issues. I would have rather had one implant and created a little bit larger crown. Remember, implants can only be supported if they have vascularization or blood supply. And that area was so thinned out. So they did do a 2-step process on this one where they grafted once, waited 6 months, then put the implants in. but they shouldn't have put 2 in. So I want you guys to know, when you see those thin ridges, you guys all need to be careful. Dr. Emilio, when you see anterior mandibular incisors like that, tell me what when you get that kind of referral, what's your thought process on it?
You mentioned that very clearly. It's about vascularization, bone support, enough distance between the teeth. And as you said, you had to compromise prosthetically, right? Either you will sacrifice the other lateral anterior in there and just spread the implants around, especially because the root is very short, or you just place 1 implant and do a cantilever or a larger crown.
Right, right. Okay. Hey, I'm going to share the screen, Dr. Emilio. You're up to bat, okay, brother?
Thank you, Dr. Seymour.
Good, good, good. Let me get that over to you. Give me just a second.
You can just go on the top and just put stop share screen.
I'm trying to get there, brother. Give me just a second.
No problem.
There we go. You're up.
Well, thank you everyone for joining us today. I'm going to share my screen right now. And I'm going to take it from where Dr. Seymour left it. The important thing here is going to be that I'm going to give you my perspective as a periodontist. And from that perspective, the important thing is to know, how do we attack these cases? How do we approach them? So we're going to start with the first case. And the first case, at one point in time, a clinician, a younger clinician, thought that this was a green case. And a green case in that regard means that it's easy, there's plenty of bone, the tissue was fine at the time of placement. And then that clinician thought that, well, the implant was placed a little bit too apically. What I'm going to do, I'm going to go ahead and do a pink porcelain in my final prosthetics. So this is how the patient presented to us. This is a case with adjunctive clinicians, Dr. Gobato, a good colleague of mine. And what you see in the radiograph is, well, the implant seems to be integrated, so it looks great. Well, but look at the slide on the left side. High smile line, triangular shaped teeth, gummy smile, if we might call it that way. There is a diastema and distal aspect of the lateral. There is a translucency of the metal showing through the gingiva. And you could see the pink porcelain where the patient smiles. Patient is horrified. So at this point in time, this case is no longer a green. At this point in time, it's actually double black, because I actually don't know if I should remove the implant. If I remove the implant, I run the risk of affecting the adjacent roots. And how am I going to approach this case? Well, putting your thought process together, we remove the prosthesis. The crown on the number 9 is actually also a ceramic crown. So we remove the ceramic crown number 9 and also the ceramic crown with the pink porcelain number 10. And we place, just for the record, we place that impression copying just to illustrate the wrong position of the implant. So now we don't only have a very minimal amount of tissue, we have all the other components and variables that make the situation very challenging. So now it's perhaps a diamond, or perhaps it's a double diamond. Now, how do we approach this case? Well, the very first thing we do is we approach this case to solve the mucogingival deformity. That means the lack of soft tissue. And for that, we do autogenous soft tissue grafting on the site of the implant once we have removed the prosthetic components, and we let Mother Nature to take care of everything. 8 weeks later, which is actually the time of healing of the epithelium and the connective tissue, then we can re-enter the site at 8 weeks to be able to see what we have obtained. And you could see the picture in the upper right side corner of the screen. You see a better thickness of tissue. Still, the implant is still in the incorrect position. The good thing is that the implant, as you see in the lower left picture of the screen, the bone and the buccal aspect is still present. In the malposition, but it's still present. So it's not a bad thing. So here we're still having a double diamond because we have not corrected the apical position or the malposition of the implant. And perhaps we will not be able to correct that. But what we understand is that at the specialty level, we start thinking about how to modify biology to work in our favor. In this case, in the right side of the screen, you see a picture with a crown and a concavity. The concavity in the emergence profile. I remember when I was in school and in training, they taught us to make a convexity instead of concavity, and that convexity was going to have the emergence profile of the crown emerging from the gingiva. But in this particular case, a concavity will help us to preserve the thickness of tissue in the buccal aspect. Yes, I agree. The temporary restoration, number 9 and 10, at this moment, they look horrific. And God forbid we want to send someone home with that. But that is going to accomplish the purpose of preserving the tissue in the buccal side. And that's all we are caring about in this particular stage of the process. It's still a double diamond because you still have not corrected the rest of the problems that we said before. Now, when a patient is looking for maximum aesthetics and the patient presents with a gummy smile that this is one of the cases, what we need to do is a crown lengthening procedure in the adjacent teeth. So the picture on the top part of the screen is the dimensions of the teeth prior to the crown lengthening. And when the crown lengthening is performed, we want to make sure that we accomplish the correct biologic width, which is the distance between the bone and the prosthetic margin, or the CEJ, which is about 3 millimeters, as is shown in the picture in the lower right side corner. Now, what you see in here is that now we're correcting part of the gummy smile. Now, this becomes perhaps now it's not double diamond, it starts getting better. It's a diamond, so it starts getting better. Okay, 8 weeks later, as the epithelium has healed, we have now a gap or spacing that forms between the two central incisors, as we've shown in the upper left side corner. Well, the problem with that is that now we know that the patient has triangular shaped teeth, and we knew that before. So number 9 is a square, number 8 is a triangle. But because we had to replace number 9 and 10, you see the final prosthetic restoration in the lower right side corner of your screen. It shows that concavity in the final restoration. Yes, indeed, the implant is still in malposition, but we have now thickness of tissue. We have the correct position of the tissue in everywhere else, but we protect that concavity to make sure that that tissue will survive on the long run. Now, what you see in the lower left hand picture of the screen is that the crown on tooth number 9 is made with an attached veneer. So the number 8 in the mesial aspect was prepped for a veneer, only a proximal veneer, not the whole tooth. So now number 9 has a proximal veneer to number 8. And independently, number 10 was restored with a single ceramic crown. So now this becomes a blue diamond because now it's prosthetics. A lot of the things are getting better. So at this point, this is the final restoration. So you cannot even tell, right? So now the patient has a high smile line, the tissue is corrected, the profile of the teeth is corrected, the gingival anatomy and contours are correct. So this is what a specialist can do for you. It's not what we thought at the beginning, it's where we started and the thought process that we carried forward to move to correct this problem. Now, as a procedure itself, was it too complicated? No, it was not a complicated procedure. Ultimately, what it was complicated is the thought process, how we're going to address it, and how we can modify biology with our armamentarium. Now, in that regard, let's look at case number 2. And then I'm going to start with the final picture again. Which one is the implant? Well, Some people will say, well, maybe number 10, it looks like a bit reddish in the tissue, number 10 area. Maybe actually number 8, the gingival in the distal line angle looks a little bit crummy in there. Well, but overall, it's very hard to determine which one is the implant, right? Now, this could be a very complicated process at the very beginning if I show you where we started. And this is where we started. So in this particular case, we have a patient that presents with 2 central incisors that are severely resorbed. Now, not every patient that has root resorption needs to have the teeth removed. Okay. In this particular case, the patient had a grade 2 mobility in those 2 anterior segments, 8 and 9, and she did want to have it replaced. The problem when we have a root resorption in number 8 and 9 is that in the picture, it shows a concavity, and that vocal concavity is going to be a problem because if I elect to go ahead and place implants in there, first of all, 2 implants together, I may end up losing some of the proximal soft tissue, right? Second thing is that I have no bone to accommodate the implants from the vocal lingual direction. So it's compromised. So maybe my solution is not implants. Maybe my solution is a 4-unit bridge between 7 and 10, or maybe from 6 to 11, right? Or maybe I extract 1 tooth, I graft, or maybe I extract the 2 teeth and do the bone augmentation procedure. So it's kind of complicated. So what I'm thinking from the specialist perspective is, how am I going to preserve the gingival anatomy on this case? So what I did before I started removing the teeth, I performed the ridge augmentation immediately in the vocal concavity. That will give me the ability to be in a better position when I remove these teeth and place the implants, right? But my gingival anatomy and the gingival margin is not affected. So therefore, this is a technique that I developed and is submitted for publication, so it's going to be published soon. So it is called a HIMBA technique. It's a horizontal mid-vocal axis, right? So with this technique, we leave the gingival margins intact, we elevate the vestibule, we place our bone graft, we're able to place our collagen resorbable membrane, and then we close it in a full closure, still a double diamond, because it requires a heavy training for this. Now, what you see the picture on the left side, the upper left side corner, is a picture that is at the time of surgery. And 6 months later, you could see that the line of incision was hidden through the mucogingival junction. So what you see in the lower left side corner is the slide of the CT scan at the position of number 8, one of the teeth that have to be removed. And the picture on the right side is the vocal lingual cut for that CT scan. And what you're observing here is now we have enough volume from the resorbed root and the vocal aspect to do anything we want to do. Now the choice in here was next. Are we going to go ahead and remove the 2 teeth and place the 2 implants together? Maybe not, right? The patient still have mobility. The patient still wants to replace those 2 teeth. Now, what is it that we need to do? Well, we can remove the teeth and not do anything as a simple extraction and let it heal, do a socket grafting and come back later. Or we could do immediate placement. In this case, we chose to do an immediate placement. Remember, the implants will be placed in the most ideal prosthetic position. So towards the cingulum of the adjacent teeth, right? Now, okay, I have the implants. Now what? How am I going to preserve the gingival architecture in there? Well, I could grab a temporary crowns and place them in there, or I could just put my healing abutments and let it heal. Do I graft the gap in between the implant and the bone of the alveolus? Maybe not, or maybe yes. So let me show you the thought process. What we ended up doing now is becoming a little bit better because now it's not double diamond, now it's have enough bone, so now it's a single black diamond. I utilize the teeth, the patient's teeth, and I use them as a temporary restorations. Those patient teeth, they have a quality that they are full crowns, they are aesthetically correct, in correct anatomical contours, and what I did is I hollowed them. I put 2 temporary copies, as the picture on the left shows. I did direct intraoral pickup with composite resin, okay, covering the chimney to make sure that none of the resin goes into the chimney of the implant screw. And I join them together. Then I pick them up in the, outside the mouth and finish them outside. So what you see in the picture in the lower right side corner, that is the emergence profile subgingivally. And what that means for you is that I was able to contour and under contour the concavity that I mentioned before, because that now my priority number one is not only to preserve the tissue in the vocal aspect, is to preserve the papilla between the two implants, preventing the collapse. Whereas we know in the literature, it shows that when the two implants are placed together, then we have a potential collapse of the interproximal papilla, which leads to a black triangle problem. Now, with that alone, now it becomes a blue diamond. It's still some level of complexity, but it's starting to become manageable. Why? Because when I did this, I went ahead and did my restorative treatment, temporary restorations on the patient the same day with the patient's own teeth. The radiograph on the right side of the screen illustrates the placement, the surgery at the time of placement. You see, there's no sutures at all in this particular subject, in particular part of the surgery. And you see in the middle of the concavity that I created in the emergence profile interproximally to 8 and 9, you see something that looks like bone, right? Yes. What I did, I introduced particles of bone graft, bone allograft, in between that concavity. And I covered that concavity and that gap with bone graft. Do I think that the bone graft in there is going to adhere or integrate into the emergence profile and developments? Of course not. But what that particle of bone graft is going to do for us is going to provide a structural support for the papilla. So the papilla is not going to collapse. So now you have 4 months later, when the patient is ready for the final impression. You see the gingival contours, they have maintained. Now look at the papilla. It's in the same spot as I placed it when we left the office. At this point in time, I send the patient back and say, Dr. Seymour, this is your patient. Go ahead and restore this and finish the case. And Dr. Seymour, I'm going to pay the favor that he did for me, sending me the good implants, the easy ones. I'm going to pay back, say, you know what, now from here on is an easy case. Just 15 minutes appointment, you go ahead, take the impression, do the scanning, send it over, receive it back, and place your final crowns. So at this point, then you have a slide that shows the 3 years after the final restoration is made, right? So in this case, look at the radiograph 3 years after the crowns have been placed. The gingival contours are still there, the papilla is still there, the under contour of the emergence profile, and the bone that remains supporting the papilla. See? So that the case itself, it was not difficult when I show you the recipe. But to get to the recipe and to make the recipe is hard because you have to have all the concepts with you. And that's the way your specialist is going to think. So it is important, as Dr. Seymour stressed, to work directly with your specialist. Now, I'm going to say something very clearly here. The big advantage that you have working in a group like Pacific Dental is that you have all the specialists within one particular office. And if you have a doubt, you don't have to call the specialist on the phone. The specialist is going to come and be in your office, and it is going to be a mutual nourishment, not only mentoring from the specialist to the general clinician, also vice versa, because we also learn in the everyday basis how the approaches of the general clinicians are going to be. Now, I'm going to show you one last case, and this is a case that actually is a multi-team approach or multidisciplinary treatment. And you see the use of different specialists what we do. This is our patient. Obviously, for HIPAA purposes, we have to block part of the face and the eyes. But what you see is this patient presents with this type of occlusion or malocclusion, okay? Now we're looking at the pictures on the right side, and we're thinking, this patient needs orthodontic treatment. but it also has some spacing in the mandibular segment. It has a pathological migration, or what it appears pathological migration. Look at the picture in the lower right side of your screen. The indentations of the contralateral teeth or the opposing dentition are already putting their marks in the lingual aspect. So I know that there is a fremdus and this patient has mobility on the anterior teeth. Furthermore, when you look at the radiographs in the maxillary anterior segment, you look at there's a tremendous amount of bone loss in there. Look at from 7 through 10, right? Look at 8, look at 9. It's almost outside of the envelope. Now, we have problems in here. We have malocclusion. We have teeth malposition, BDO collapse. Perhaps one could argue that we have excess of the maxilla. And then we start thinking, well, we'll probably employ our oral surgeon to be able to do perhaps Lefort procedure or osteotomy on the bone to correct the malposition of the bone and to probably correct that occlusion in conjunction with the orthodontist. Or maybe we say, you know what, I'm going to send it to the orthodontist immediately. That's good, right? How many of us, and again, we'll raise our hands, how many of us will choose to send this to ortho right away? Well, we're crazy. We're not crazy, right? We're crazy sometimes, but in this particular case, we're not that crazy. Because if we do orthodontic treatment in teeth that are periodontally compromised, we're going to just exacerbate that periodontally compromised and we end up losing the teeth. So we know that the orthodontic treatment at the beginning is not the right choice, right? Luckily for us, as we could see in the posterior segments, the bone levels are not too bad. It's mainly possibly the secondary trauma from occlusion and the teeth malposition that caused this bone loss in the anterior segment. All right, so what are our choices in here? Let's go back to the first picture. Our choices are, well, we do a Lefort to reposition the maxilla, but we still have that problem. We extract the anterior teeth and we place implants, or we do an Lefort and we do a full rehabilitation where we have to do orthodontic treatment from the mandible. And then once we do that, we remove all the teeth in the maxilla, we reduce the bone by alveolectomy, and then we'll put our 4 or 6 or 5 implants across to do a hybrid removable prosthesis or fixed prosthesis, right? But let's look at the recipe. The recipe in here was very simple. We did put the patient in orthodontic treatment. So the picture on the left side, the upper left side, is the beginning of the orthodontic treatment. And through the next 6 to 8 months, we had a picture in the upper right side corner. You see, we started correcting the malocclusion. But wait, didn't I say that we shouldn't do orthodontic treatment for periodontally compromised patients? That's correct. However, we know that, as you see in the picture in the lower left side, we were planning to remove the anterior segment and those teeth. But what we're doing with the orthodontic therapy, doing the retraction of the maxilla, so that way we will be able to accommodate a correct interarch correction, so the maxilla is in a better position with the mandible. This case with the great clinicians, Dr. Roger Weiss back in Boston, in our Boston market, fantastic work for orthodontic treatment. And then you see the extraction of the teeth have been done, right? Now, okay, now I'm ready to place my implants. Wait, not yet. You see where the gingival margin in the edentulous ridge in the lower right side picture, you see where it is in correlation to the mandible? We still don't have the correct space. But we have a lot of bone loss before, right? And we see the preps in the adjacent teeth, in the premolar and the canine areas, right? Okay, so what we go is we go to the lab and we perform a surgical reduction of gingiva in the lab to create enough space for our prosthetics. We have a diagnostic wax up, and then we have, in the lower right hand picture, we have a surgical stem or surgical guide. Surgical guide, which is the replica of the diagnostic wax up. But why am I going to do surgery? Am I going to be placing the implants? Wait. So what I'm going to do in the next phase, I use that replica of the surgical wax up as a surgical guide, and I will calculate the amount of distance that exists between the gap of the margin of that surgical wax salt and the gingival margin. And you see that calculation? Well, that calculation, the lower left side of the screen, is translated to an scalloping incision that needs to be done on the gingiva. Then in the upper right side corner, you see the removal of that soft tissue. And after the removal of soft tissue, we need to do some bone alveolectomy and smoothing. So we are able to collapse the gingiva, as you see in the lower right side. And then there you have a temporary restoration that is delivered at the time of surgery that has some level of ovate pontics to be able to push on the gingiva to start creating some gingival anatomy. And you see the picture on the lower right side, the casting of the ceramic restoration that's going to be the final ceramics. So where are the implants? No, they are not implants, right? And this is the final restoration placed in the patient's mouth, right? So you could see the before and the after. And the recipe was very simple, right? But it's not about the recipe. It's about the ability to communicate with your specialist to be able to formulate a treatment plan in benefit of the patient that is not difficult. It's simple, but you require the thought process of what your armamentarium can do based on biology. So I'll leave you with this slide.
Doctor,
yes.
Can I ask you a question real quick?
Please do.
Okay, so you had ortho, you had perio, and then you had GP, and you
Yes.
were kind of all mixed in and kind of consulting each other. You also had the lab in that conversation. How would you tell the lab to create that stint or that reduction, that bone and gingival reduction guide? How would you phrase that, or how would you tell them that?
That's a very good question. You know, when we look at doing our surgery and when we want to accomplish what we need for surgery, the model that you see in here is we did the reduction. We did the reduction on the model because we needed to know exactly the level of spacing that we needed in communication with you, the general dentist or the restorative dentist, to be able to communicate that. So I did the reduction on the model, and then the lab, I said that to the lab and said, please do a diagnostic wax up and send it back so I can approve it. Once they did diagnostic wax up, I said, great, I like it, or if not, let's modify it. Then go ahead and duplicate the wax up into surgical stent.
And then you had the GP prep out the crowns.
Exactly.
Right there. Yes, and then you kept your posterior stops
Exactly.
back on the molars. Okay,
Yeah.
so I'm following
You see the picture in the upper left side, the posterior stops are there, right? So yeah, right on. And with that, we were able to deliver things, right? So it's not complicated. It's just communication. And again, I cannot stress enough. I've been working with the PDS group for over 12 years nowadays. And I could tell you that the biggest thing that I have taken home from this collaboration was the communication in the same setting, that you don't have that luxury in the private practice, right? I own a few private practices throughout the different states, but I don't have that ability. So I cannot praise enough the group of Pacific Dental Services to have us to be all together to have this communication flow of flawless, right? So I'll leave you with this last slide, which is you are as good as your understanding of your abilities and limitations. It says limitations, it's a typo there, it's limitations. So we work together, we are one team. And with that, I'll leave you with the information that Dr. Seymour or myself, before the introduction, which I appreciate that from Dr. Seymour. I'm also a core faculty at Harvard University back in Boston, so you can reach out to me directly. That's my email. And follow, those are the tags, the hashtags for following Dr. Seymour and our doings for Pacific Dental. Thank you very much. And then now open the floor to some questions. And we have Kim that will help us to moderate on the floor a little bit.
Yes, thank you both so much. And, certainly attendees, if you have any questions, please put that in the chat. In the meantime, I do have a video of Dr. Seymour that he put together. And so I'd like to play that. He'd like to have that played for everybody for just one moment. So let me
stop sharing it here, and then it's all yours.
Perfect. Thank you so much. Okay.
And while you're putting that together, I'll walk you through this implant placement. And I hope that it gets you excited for dentistry, because it can be, you know, I was just chatting with a patient today, just how much you can really help people. And when you have that team effort, that specialty team, and you guys are all locked in, and you know the products you're going to use, you know what the steps are going to be, and you've got that open line of communication, it can be remarkable. I actually think that this is the future of dentistry, as in a more comprehensive footprint and a more comprehensive approach to it. So fascinating. It looks like there is a question down there from Ashley Wynn.
Yes, she asked, Dr. Emilio, the last case, do you place implant for the front teeth or just a bridge for the patient? My apology if you already said this and I just missed them.
No, thank you for the question. In that particular case, we did not place implants. And that is because actually the case was done pro bono and the patient did not want to have implants, period. So that goes to illustrate that implants are not always the choice that we elect to do in our patient care. There are many other choices which are valid, and with the clinicians like Dr. Seymour, for instance, that is a very well-knowledgeable, very well-trained clinician, we can achieve these results without the implant process. But could you have placed the implants in there? Absolutely. You could have elected to place implants there, probably in the position of 7 and 10, and to do a 4-unit bridge, implant bridge. Or if you have some deficiencies, you can also choose lateral and one central, and cantilever one lateral to the other side. There are different choices there according to what we encounter, but great question. Yes. In this last case, we did not.
Okay, so I'm going to play the video. Please let me know if you can't hear it or have any disruptions.
All right, this is your classic green run. This should just enjoy just kind of watching this and the process, the thought process on this. Okay, you've got plenty of space there. You got keratinized gingiva. You've got plenty of length there. People ask me about that canine that's laying in the chin. Don't worry about that. That's not in the game plan. That's what thick bone looks like. You know, you do a full thickness reflection flap. Should be very well anesthetized. People always ask me, okay, what can I do to get ready for real life dentistry? Get good at getting people numb. That is what holds people back a lot. What else? Get to know, be with your specialists. Get in there with them. Watch their process. Watch their surgical sterile field. It's just remarkable what you can do. PDS does have a special relationship with Nobel BioCare. So for those of you that are familiar with those products, we also do use other products as well. And this is a Nobel BioCare system. Dr. Emilio, what systems do you use, or do you use all of them?
In most of my practices within PDS, if not all, because of the relationship that we have nurtured over the many years with Nobel BioCare, that's our implant of choice. And when we do that, for many years we place actives, and nowadays we switch to the conical connection, taper or parallel, depending upon the case. Great implant, we have had great success. Now, in other practices and to the choice of the clinician, sometimes we change the systems, that we work with about 10 different systems. But our system of choice certainly has been Nobel BioCare for many, many years.
Right. Let me get back to this video. After the osteotomy is completed, we do a test check or an angulation check. My biggest worry during implants, both when the GP restores them and during placement, is dropping things down the patient's throat. So most of my patients are seated upright, And if I do have a posterior one, I do have a throat catch. This one I needed I couldn't do that for the video. It just got in the way. Right before implant placement, sterile saline, make sure the area is very clean, and the bony walls, I'm totally contained within the bony walls. Okay, and then we're going to final implant placement. What are the big misses of new grads with implants? They don't know their connections. They don't know their components. And so this is a conical connection. Conical connection is a wonderful, wonderful connection. Man, it's great. And this patient was ideal. It was ideal because of good keratinized gingiva, thickness of bone was excellent, great spacing, patient communication was really good. As in, the patient knew exactly what he was going to get. I like to leave 2 tine or threads above the bone so I can insert it all the way. You can watch this video. I'll leave the link in the comment section here, or and you can just click on that. So I'll just put that in, and you can watch it for yourself. Okay. But I hope you guys get excited for treating patients. We are kind of dealing with the COVID, and we are getting over it. Our staffs are fully covered and fully shielded, and for a couple months there, we were only doing emergencies, no cleaning. Yeah. Dr. Emilio, how was that for you guys during COVID for perio?
We were in the trenches, as you said. A lot of our clinicians, in conjunction with what you did, we were doing extraction, we were doing emergency, patients with high risk for comorbidities. But we've been here. We've been taking care of our patients with all the protections necessary, protecting the patients, protecting our staff, and we've been good. But thanks for the question. Yes.
Yeah, good. I think there was another question. I think you might be able to answer this one, Dr. Emilio, on the chat. It says, I watched some of the BioCare implant webinar. They recently recommended the 4-in-1 system. Can we GP do the placement for it, or would it be referred to the periodontist? All-in-4s should be reserved absolutely for the periodontist. There's a lot more to this, the all-on-4 system, than meets the eye. And it should be a team approach, so there's multiple people looking at it. Dr. Emilio, did you read that question differently? Or
yes, I did. No, I just read it, yeah. So I happen to agree with you. Now, this is a very important part of it. When you start placing implants for the first time, for all of you that have not placed implants before, you will learn very quickly that implant placement is not difficult. Actually, it's quite simple, right? If you're handy, if you have a good concept, you can place it. The problem is, like Dr. Seymour just mentioned, there's a lot of things that we ignore and we don't know that can go wrong with the implant placement, especially in all-on-4, full mouth rehabilitations, VDO, implant failures, implant prosthetics, implant components. And yes, once you have many implants under your belt, if you want to venture into that, yes, but get trained. Get the proper training. A weekend course for all-on-4 is not going to cut it. And believe me, I teach the course. We have a special training where we do one-on-one training, clinical training in different locations in the country and outside the country. And that's the biggest problem that we have. The clinicians don't always look at all the aspects that Dr. Seymour mentioned that will lead to a successful case.
Yeah, and I have to 100% be with you. Here's what I see with young associates. So I probably had 50 or 60 that I've personally mentored. What would I do? Find a good mentor. Find a mentor that is in a good group of specialists that can really help you. And PDS really has the perfect culture and the perfect system for that. But, you know, that is how you develop those skills. Number 1, be able to numb patients first. Number 2, restore a handful of these. Number 3, watch when the specialist has troubles. They are not, you know, they are not perfect, and because there's limitations to our bodies. So if an implant fails, link up with the specialist and ask the specialist, tell me why you think that failed. And they'll say, well, it's posterior maxilla, poor quality of bone, and we were swinging for the fences on that one. It's a double black diamond. Well, as the years go by, you all of a sudden realize that there's some subtleties to this that are really remarkable and are to be revered, and to kind of sit back and watch and be like, this is remarkable. When I watched Dr. Emilio do that, like as I did this, I can tell that there's been hours and countless times where he sat down and thought this through over and over. And maybe he's had to go through kind of the trials too of cases not going right. So when you think about green or an easy run, when you do your first green, you want to be with a mentor, and it should look like that one that we showed at the beginning. It shouldn't be like, hey, let's all jump in on an all-on-4. Woo! Talk about trying to eat a deer in one bite. That would be very hard.
Yes.
Very hard.
Another thing that I happen to agree very much, and to your point, Dr. Seymour, I think, unfortunately, many specialists, and outside our model, because our model is conducive to that, as you said, many specialists think that if we share our knowledge with our clinicians, they're going to eat away the pie, and we don't have any part of the pie. The reality is that that's not. We have a system that is nurturing system where we both learn from one another. And what Dr. Seymour said that is very key for this, find the right mentor, someone that is willing to teach you what the implant dentistry, what surgical is about. The more you learn, the more you will understand your limitations and the cases that you can do.
Yeah. Excellent advice. Excellent advice. Kim, I don't have anything more. I don't want to keep you longer than needs be. Dr. Emilio, did you have anything more?
No, I really appreciate the opportunity to be here with you guys, and let us know, let Tim know if you have interest in other type of seminars. We can certainly develop those for you and keep you right on the loop.
Yes, absolutely. On behalf of University Relations, we thank you both so much for your time this evening and educating all of us about the opportunities of better collaboration between the GP and periodontist. And as the doctors were mentioning, some of you may know Dr. Seymour. He's taught a few implant boot camps for University Relations. And so if this is something that you'd like to bring to your school to have more of a hands-on experience live, please reach out to me. We'd be happy to help coordinate that this fall, or certainly next spring, whatever works best for you. And for Dr. Emilio, he does some amazing webinars and has different educational links that certainly reaching out to him, he'd be willing to share. It's pretty outstanding. So we have two experts that have a lot of information to continue to share. So we're so thankful to have you both, and wish everybody a great evening.
All right, Kim, we'll see you later.
Appreciate it. Bye-bye.
Take care. Bye-bye.